think we're going to go ahead and get started. So my name is April. I am a member of the National Political Education Committee. I'm also a member of North Texas DSA. I am on in the SocFem work group as well. So welcome. Thank you for joining and signing on. This is the third of 3 events that's hosted by DSA's National Political Education Committee on the COVID pandemic, and basically its relation to capitalism. So the National Political Education Committee both hosts national events and provides support for our local political education chapters through training, peer mentoring, educational materials, and so on. So if you are doing political education work in your DSA chapter and you'd like to get in touch, you can contact us through email, and somebody is going to drop that email in the chat right now. So we do have 2 amazing speakers for you tonight. The first speaker is Gregg Gonsalves. Gregg Gonsalves is an associate professor adjunct of law at Yale Law School, the co-director of the Global Health Justice Partnership, and a leading HIV/AIDS activist. Gonsalves is also an assistant professor of epidemiology of microbial diseases at Yale School of Public Health. His research focuses on the use of quantitative models for improving the response to epidemic diseases. And for more than 20 years, he's worked on HIV/AIDS and other global health issues with several organizations, including the AIDS Coalition to Unleash Power, the Treatment Action Group, Gay Men's Health Crisis, and the AIDS and Rights Alliance for Southern Africa. He is going to be our first speaker. So Gregg, whenever you're ready, you can take over.
Can you see?
We can.
So in the time that I have with you today, I just want to take you through a little sort of tour of AIDS activist history, and then sort of talk about how it sort of leads us up to the current moment. You know, I'm a public health person, and you know, one of the first things you learn in public health school is that pills and health is not just about sort of medicine and the sort of things that happen to you in the doctor's office. It's a whole set of social determinants of health that start with your age, your sex, constitutional factors that go all the way up through social and community networks, living and working conditions, social, economic, cultural, environmental conditions. This is not a new thing. Friedrich Engels wrote a book called Conditions of the Working Class in England in 1845. And Rudolf Karl Virchow, who's the father of social medicine, did a report on the typhus epidemic around the same time. Both came to the conclusion that people live in working conditions that make them sick. So the idea of social determinants of health is a pretty old idea. And Virchow wrote in one of his books that medical statistics will be our standard of measurement. We'll weigh life for life and see where the dead lie thicker among the workers or the privileged. And this could be a description of social epidemiology as much as it's a sort of foundational text for social medicine. So before we talk about HIV, I think, you know, depending on how old you are on this call, you remember the second half of the 20th century with more or less detail as history or as part of your life. And I graduated high school in 1981, and you know, the Great Society programs, the civil rights era, you know, we're 10, 15 years old now, and a new sort of culture of selfishness and greed arose with the sort of rise of Reaganism in the United States and Thatcherism in the UK. But Tony Jett wrote about this in a book called Uber's Land just before he died of ALS over 10 years ago, and talked about something being profoundly wrong with the way we live today. And just think about the economic, the social, the cultural markers of 1980s Reaganism and this new epidemic that sort of shows its face. This is an iconic picture that showed up in Life magazine in the 1980s. This is my cousin Carl and my good friend Jay Funk, who died of HIV. I also have HIV. But this is a deeply personal experience for me. Many of us are experiencing an epidemic for the first time in our lives. This is round 2 for me and my friends. Oops. that stuck. You know, and Vito Russo, who wrote a book called The Celluloid Closet, was a notable film historian, who's a part of ACT UP, said it's really hard to describe what the living through the AIDS epidemic was the first time around in the 1980s. It was like being in a war, except nobody knew what was going on. Every time a shell explodes, you look around and you discover that you've lost more of your friends, but nobody else notices. It's not happening to them. Only you can hear the cries and the screams of the people who are dying and the cries for help. Nobody else seems to be noticing. This was the context of the AIDS epidemic. I think it's a lot different today when we talk about COVID-19. You know, my foundational education was in ACT UP, New York, the AIDS Coalition to Unleash Power. And if we talk about the political determinants of health, I think ACT UP, you can see, tells as a political issue and recognize that there are not only social but political determinants of health. And we had an iconography and used art to get our point across. These are some of the sort of iconic graphics of that time. Why is Reagan silent about AIDS? What is really going on at the Centers for Disease Control, the Food and Drug Administration, and the Vatican? Gays and lesbians are not expendable. Use your power, vote, boycott, defend yourselves, turn anger, fear, grief into action. These posters were on lampposts all around the East Village and all around Manhattan and Brooklyn and Queens, also all around the country, wherever there's an ACT UP chapter in the 80s and the early 90s. And there are lots of variations on this poster. One is Red Koch on that lamppost. This one is sort of the generic government has blood on its hands poster. You can see we tied the sort of the politics and actual policies and programs of the Reagan administration into part of our sort of actions that we did as part of ACT UP. This is one of the posters for that was called AIDSgate. And again, I think you should look and see how we use sort of visual art and art and propaganda to make our case. These were arresting photos and pictures in a media environment that wasn't quite as saturated as ours is today. Another one that gives you a sense of what we saw as confronting us 30, 40 years ago. It's pretty clear that we could just swap out the picture for Donald Trump right now, and this would apply to COVID-19. I think we were making broader sort of analytical claims on what was going on in terms of the AIDS epidemic, in terms of how much we spent on defense rather than healthcare. But this sums it up in terms of how we thought about what was going on with HIV. This was Independence Day in 1989. And we said government continues to ignore the lives, deaths, and suffering of people with HIV infection because they're gay, Black, Hispanic, or poor. By July 4th, 1989, over 55,000 people will be dead. Take direct action now, fight back, fight AIDS. There are now over 80,000 dead from COVID-19. So think about what that means. Think about taking direct action now, fighting back, and fighting COVID-19. So, you know, the artists among ACT UP were pretty awesome. This poster for Enjoy AZT was about the price of the first AIDS drug, which Tony Fauci from the National Institutes of Health has said remdesivir, the new Gilead drug, is like the AZT of COVID-19. Well, this drug was the most expensive drug on the market ever back in the late 80s. And my friend and colleague, Peter Staley, riveted himself into the offices of Burroughs Wellcome with steel plates and metal bolts. And they took over the New York Stock Exchange and threw fake dollar bills onto the trading floor saying, "Sell Welcome." A week later, Burroughs Wellcome dropped the price of the drug. So, you know, we were doing interesting art, interesting activism and direct action, but we also sort of wade into policy, right? We really opened up experimental access to new AIDS drugs and sped FDA approval. You know, we put out a national AIDS treatment research agenda every year, which sort of analyzed the sort of gaps and redundancies and the flaws in the National AIDS research program. None of us were physicians, none of us were scientists. We were all doing this as, you know, 20-something, 30-something autodidacts who were, you know, sneaking to medical libraries to learn the science and reading whatever we can to sort of understand what was happening around us. But we also did important community-based research. You know, PCP pneumonia was a leading cause of death for people with AIDS, and the National Institutes of Health was not interested in doing these studies because it was on something less sexy than the new virus that had just been discovered. But so in addition to sort of the art and propaganda, the direct action, the reports we did that changed policy, we did medical research too as a community-based initiative that was part of our advocacy and activism. We also pressured drug companies not only on the prices, but on the clinical trial designs of the studies that we were in. We did other things. My friend Julia Marcus has a article in the Atlantic magazine today talking about this pamphlet from Joe Sonnabend, my old doctor, and one of his patients, Richard Berkowitz, called How to Have Sex in an Epidemic, One Approach, which was the invention of safer sex, where they first sort of talked about handing out condoms to prevent HIV infection, even before the etiological agent of the disease, before HIV was discovered. And Julia's talking about how we have to think about harm reduction and in the context of COVID-19, because we can't necessarily sustain these total lockdowns for much longer. But we invented needle exchange to prevent HIV transmission from between people who use drugs. We made laws to protect people from discrimination. These are the Ray brothers who were bombed out of their house in Florida. This is Ryan White with his mother up at top, again, thrown out of school for being HIV positive. So we were sort of taking matters into our own hands, politically, policy-wise, programmatic-wise, research-wise, advocacy-wise, media-wise. We had a sort of full-scale advocacy approach to dealing with the AIDS epidemic. But none of it came easily. Direct action was a big part of the work we did. You know, these are pictures at the National Institutes of Health and at the Food and Drug Administration. You can't get anywhere near building one. You can't get anywhere at the NIH now in the sort of post 9/11 environment. But these are bucolic campuses that, or residential suburban campuses that, you know, never see this many visitors, let alone protesters, and thousands of people descended on the NIH back in 1991, I think, or 1990. The FDA demonstration was several years beforehand. In addition to the policy work we did, the direct action work we did was incredibly important in sort of getting the federal government to take notice and to listen to what we were asking for. I think, you know, my friend Amy Kapczynski from the law school and I wrote a series of 3 pieces in the Boston Review over the past few weeks, talking about where COVID-19 came from, right? And the sort of roots in the sort of neoliberal late 20th century capitalist superstructure that we live in. But I think, you know, we also talk in the piece about how it goes much deeper into our history, buried in our geography. All the stuff I've been talking about, these social determinants of health, these political determinants of health, the sort of scars of the AIDS epidemic are really are buried in our geography. They've played out across real bodies for decades, if not centuries, in the United States. This is a map of the concentration of slaves in the South right before the Civil War. Look at this crescent here. Now look at this crescent here. This is life expectancy, you know, over a century later, and the sort of scars of white supremacy still live in the United States in terms of who lives and who dies pre-COVID, you know, 6 years ago. And, you know, if we think about who's dying today in greater numbers, it's again, counties which have been hard hit for decades, over a century from sort of health disparities, or seeing health disparities play out in the context of COVID-19. I'm just going to turn off my screen. How much more time do you think I have? Keep going.
Yeah.
Yeah. So this is my history. I come from ACT UP, and what's been interesting since January, February is that, you know, the old AIDS activists, you know, who are, you know, my age or older, are still here. There are people who've come up through the movement, which is now sort of broader than HIV. It's, you know, if I'd had some time, I would have talked to you about my work in South Africa around TB, my work on hepatitis C, and access to the new drugs for drug users. But this whole sort of right to health movement that's grown up over the past 30 to 40 years is now sort of confronting COVID-19. There's a COVID-19 working group in New York City, and it's a lot of the old AIDS activists, the old AIDS docs, and some of the newer young people who have been part of this movement, and they're doing lots of stuff that we've talked about in the context of the AIDS epidemic. We're wondering, where the fuck are the tests? Why have we screwed up the testing situation so drastically in the United States? Why are we doing clinical trials of drugs like hydroxychloroquine, which we know don't work, when we have drugs on the shelf that most drug companies and the National Institute have not screened for anti-COVID effectiveness? I talked about needle exchange a little bit in the presentation I showed you, but many of us are working on behalf of incarcerated communities, people who use drugs, sex workers, other people who are street involved, such as people experiencing homelessness, to sort of figure out how to keep them safe in the context of this epidemic. And that means working with lawyers here at Yale and other places around the country to use the legal system like we did in the early AIDS cases around the discrimination to get people out of jail or ICE detention. But we didn't stop at that. Here in Connecticut, we did a hunkathon around the governor's mansion twice last month and around different prisons in the state over the past few weeks. We haven't had great success in getting our governor, Ned Lamont, to do the right thing here. But again, sort of the architecture of the work that we're doing now is very familiar to me in the context of the way we did it back then in the 80s in terms of our mobilization of expertise, putting our bodies on the line in direct action, and using the media to get our messages across. I think one of the things that's different about activism in the COVID era is that it's a bit of an imaginative challenge. I think the big issue for me is COVID-19 makes the AIDS epidemic look like child's play. We're going to have close to between 100 and 200,000 people dead from this disease at a low estimate. By the end of the month, there's an expectation that every 3 days or every day we'll see anywhere from 900 to 3,000 people a day dying by the beginning of June, which means that's the Twin Towers falling every 3 days or every day, depending whether you take the 900 per day or the 3,000 per day casualty measure from the models that have suggested the trajectory of the epidemic by Memorial Day. And so we have a catastrophic epidemic facing us. We have no political leadership. There's an article going to come out on Thursday in The Nation that I wrote for them, which basically says, get ready for the slow burn, because we're going to see sort of sustained deaths over the next several months leading into next year with no end in sight, because the option we had to test, contact trace, and isolate and support people economically and socially through this period was basically given up upon by the White House and by the Congress. And so we are basically in for the long haul, but we're going to see lots of people we love and care for get sick and die. The funerals I remember from the 1980s and 1990s, get ready to put on the black suit again and get ready to mourn your dead. The challenge for, I think, DSA and for the veterans of ACT UP that are part of the COVID-19 working group who are already mobilized against Trump and groups like Rise and Resist is to figure out how to make a change in this epidemic before it's too late. We all want to change sort of the underlying structures of society that have given us this epidemic, but right now we should be in survival mode and figuring out how we can sort of get our national response to COVID-19 back on track, because it's going to kill many people, but it's not going to be equal opportunity killer. It's going to kill in communities of color, and we already know from analyses by colleagues of mine at the University of Chicago that the people who are going to be hardest hit are people who are working in high proximity, low work from home jobs. That means you can't stay home, and when you're at work, you're cheap by jowl with other people, and it falls squarely on the people with less education who are at the lower range of the economic spectrum, and so it's going to kill the poor, mostly in the United States, for the next few months. So we have to figure out imaginatively how to sort of act up for COVID-19 because our communities are depending on us. We've seen a capitulation of federal leadership, state leadership, depending on where you live in the country, and local leadership, depending where you live in the country. And this is probably the greatest political challenge we're going to face in a very, very existential sense ever in our lifetimes. Nobody could have told me 6 months ago that we'd be where we are, sort of on the precipice of a pandemic that's going to create a new Great Depression and kill hundreds of thousands of people in the US. Nobody would have believed it, but here we are. And figuring a way out is probably the most important piece of work that we can all do together over the next few months as we move into a long, hot summer that's going to be painful for many of us. So I think that's it.
Thank you so much. Hold on one second. Hello, it is me again. Let me introduce our next guest. Marty Bennett is co-chair of North Bay Jobs with Justice, a community labor coalition of 20 unions and community-based organizations. He's affiliated with the National Jobs for Justice Network. He's also a research and policy analyst for the Unite Here 2850, a union representing restaurant, hotel, gaming, and food service workers in the San Francisco Bay Area. He's one of the founders of the North Bay Organizing Project, a faith-based community organizing project in Sonoma County, affiliated with the Gamaliel Foundation, and he serves on the MBOP Leadership Council. So whenever you're ready, Marty, please turn on your cam and take it away.
Hi, delightful to be here. And a shout out to meet Gregg virtually. Our backgrounds are very similar because I am a retired professor at Santa Rosa Junior College, and you see the tools of the trade in back of me. But I've also had one foot in the American labor movement for almost 5 decades. And I'm working very closely with my union, Unite Here, that represents hotel, restaurant, and gaming workers at this moment. But what I want to do is I want to talk to you about our multiple campaigns around the COVID-19 crisis in California, and starting very specifically with a campaign for emergency paid sick leave. And this campaign is going on at 2 levels. One, there is lobbying in Sacramento by an organization called the Partnership for Working Families, which is a network of 24 labor-based policy and organizing nonprofits. And then it's also going on at the grassroots. Organizations like Jobs with Justice and East Bay Alliance for a Sustainable Economy, linked to the Partnership for Working Families Network. We are moving legislation at the local level. And these 2 things are working in tandem. And I want to get around to explaining that in just a minute. But first, this large statewide coalition, I want to kind of give you what I think is our common ground in terms of, as being advocates for labor. We are working at these 2 levels in Sacramento and at the local level. One, I think the only parallel when we talk about our present economic and public health crisis is likely the 1929 crash and the Great Depression in the 1930s, which would persist up until 1941. What we have today is multiple crises. A crisis of inequality, a climate crisis, a global public health pandemic that are converging. And as Naomi and Klein and others argue, these kind of unique historical moments potentially can lead to structural change and societal transformation. And that's what happened in the New Deal in the 1930s with the welfare state, the dramatic increase of union membership, compression of wages and income inequality, and then the creation of political and social conditions that are going to lead to powerful social movements for economic, racial, and gender justice after World War II. I think we also share the common ground that the crisis has showed how broken the system of neoliberal capitalism is, and it really provides the opportunity for us to educate, persuade, and organize a substantial portion of the American population, who really at this moment are ever more open to a progressive and socialist agenda. Also, I think we share the common ground in this coalition that struggle for structural change has to be driven by multiracial grassroots social movements who align with progressive elected officials at the local, state, and federal levels and create and share a common vision for policy. Our tasks are simultaneously to build a movement for immediate and short-term survival, which is what emergency paid sick leave is. But simultaneously, our tasks are to put forward a broad agenda that looks at the roots of this crisis, neoliberalism, neoliberal capitalism, and puts out an agenda for structural transformation. And so what we're attempting to do in this campaign is we're attempting to build a movement from the bottom up that will scale up to affect the state government and hopefully the federal government over time after 2020. I think we also want to stress, as Greg mentioned, that those who are most impacted by the COVID-19 crisis, they're working class, they're people of color, women, and immigrants. They comprise the majority of workers who are giving and doing essential services during the crisis, and they are the majority who are afflicted by the disease. And finally, these constituencies are the foundation for a movement for structural transformation and change. So what are we attempting to do with paid sick leave? And I wrote an article on the website Beyond Cron in the San Francisco Bay Area. And there's a national network, Better Balance, about a better balance for life and work that does excellent work on this. If we look at the March 1st Coronavirus Response Act passed at the federal level, it did provide 14-day emergency paid sick leave. And 14 days translates into 80 hours, working hours, and roughly corresponds to the incubation period, longest incubation period for the virus. And that can be used for diagnosis, treatment, quarantine, isolation, care for children who is closed, or for ill family members. The employers receive a quarterly payroll tax to fund paid sick leave. And it was a small but an important step forward, given that we are the only country that doesn't have some form of universal paid sick leave. It is critical to any successful shelter-in-place strategy. And workers who go to work sick, they're going to pass on the disease to fellow workers or their customers or clients. They can bring the disease home from work to their family. So we have to have emergency paid sick leave. And that was an important step forward at the federal level. However, when we look at the workforce and paid sick leave, it plays itself out who has it and who doesn't by class, race, gender, and by those who can work remotely and those who can't. 90% of the highest earning private sector workers have paid sick leave. these workers are likely to be part of the 30% of the workforce who can work from home. They also are overwhelmingly white. On the other hand, only 30% of the lowest paid workers have access to paid sick leave. These workers are almost certainly to be part of the 70% of workers who cannot work from home. And a majority of these people are people of color, immigrants, women, and youth. In the federal legislation, there is a huge loophole. And what that loophole is that employers with more than 500 employees are exempted. And so the estimate is only about 20% of the total workforce is mandated to provide 14-day emergency paid sick. And so what our attempt is to do is at the local level, pass legislation, emergency paid sick, that closes this loophole. And we think of all employers, it is the Walmarts and the Darden restaurants and the McDonald's of the universe who can afford paid sick leave. And so already in California, at the metropolitan level, San Francisco, San Jose, Los Angeles, Santa Monica, and Long Beach have passed 14-day emergency paid sick, covering all workers employed 2 hours a week within their city. Oakland, San Mateo, Santa Rosa, and a number of others will soon approve comparable paid sick legislation that will close this loophole. We think we can bring pressure on the governor and the legislature to implement emergency paid sick leave for the entire state. And that's very much what happened with California becoming the first state to implement 15 minimum wage. It started at the local level. We had 5 major metropolitan areas in 2015 and 2016 with citywide 15 minimum wage. And we had some 37 cities and counties that had implemented living wage laws since the late 90s that applied more selectively to workers for county contractors or for city contractors and city services. But nonetheless, that was a grassroots movement. It brought pressure on Sacramento, and the legislature and the governor did the right thing. And so we think there's an important cards to be played here because New York has already set the precedent by implementing 14-day emergency paid sick leave. Our governor, Gavin Newsom, last week issued an executive order mandating 14 paid emergency sick leave for any workers in the food production supply chain, production, processing, and distribution. So we know he's feeling the heat. Our legislation goes further than New York, and there's many other provisions that we want. Strengthening no retaliation against workers who access emergency paid sick leave, that to trigger it, you just need to give a note to your boss. You don't need a doctor's note. Other specifics like that, including application to so-called independent contractors. Simultaneously, the legislature, bills are being introduced as we speak on paid sick and other labor provisions I'll mention in a moment. But I think the bottom line here is paid sick leave is good public policy. And 13 states and 22 cities currently have some form of permanent paid sick leave. It's demonstrably in the public interest and the essential for the renewal of a robust social safety net. And I don't want to give you all of the stats, but they're in my article. paid sick leave prevents the spread of illnesses and disease on the job to customers and clients. Local jurisdictions with paid sick experience lower influenza rates. Parents with paid sick are less likely to send their ill child to school. Employers who provide paid sick leave experience less worker turnover, and workers are more productive on the job. So Better Balance summarizes much of that evidence, but our focus is not only on emergency paid sick leave. We simultaneously are asking local jurisdictions to take up permanent paid sick leave, because we know the virus is going to come back. We know the influenza affects millions each year, and permanent paid sick leave and its expansion in California from 3 days to 10 days. This has to proceed simultaneously while we're building this movement for emergency paid sick. Just want to stop there and check in on time. How am I doing?
You've got plenty of time left.
Okay. Let me just mention a couple of things that this statewide network is doing from labor's perspective to confront the challenge of the COVID-19. And there are other pieces of legislation we're moving at both the state and the local level. One is the right to recall and worker retention, and that employers must it mandates recall by seniority for workers laid off during the crisis with comparable wages and scheduling. And it has a just cause termination provision, so employers can't take advantage of the crisis to, without cause and unfairly discharge workers. We also have a worker and health and safety protections legislation at the state and the local level, particularly for grocery, pharmacy, restaurant, on-demand delivery service, janitorial, and hotels. And it contains numerous provisions, such as mandating that all employees receive paid time off to wash hands every 30 minutes. Employer provides all the necessary personal protective gear, such as gloves and face masks, and sanitary and disinfectant cleaners. Employers provide necessary training for use of PPE and so forth. Third, we want to strengthen the enforcement in health and safety regulations. Cal Ocean is now 20% unstaffed. Positions have been unfilled. We want to mandate partnerships between Cal OSHA, local health departments, unions, worker centers, and workplace and health advocates. And that legislation would establish rank and file worker health and safety committees to provide suggestions for improvement of the workplace, educate workers, conduct trainings, and police the workplace to ensure compliance with safety standards. This is the type of policy that we think we can build a movement around that looks at immediately survival, but simultaneously addresses the huge broken dysfunction of neoliberal capitalism and begins to put forward an agenda for transformative change. And I just say a couple things in terms of the broader task of labor. One is that we have to have an economic bill of rights for all, as FDR proposed in 1954, that would guarantee every citizen a job, living wage, decent housing, adequate health care, education, and social protections for old age, injuries on the job, and unemployment. And the California Labor Federation, you can look on their website. They have a very good workers' bill of rights for COVID-19 protections that include paid sick, right of recall, worker health and safety, and others. But more expansively, Senator Elizabeth Warren and Representative Ro Khanna from California and San Jose have just introduced legislation, the Essential Workers Bill of Rights, And what this does, it's very important, is it puts bells and whistles on any company that is receiving bailout or federal money. So companies must remain neutral if their workers decide to organize. Labor law is absolutely broken and workers have few protections, but any company receiving money from the feds must remain neutral. Have to provide premium pay for essential workers, place workers on the boards of companies, give them a voice, make CEOs personally responsible for compliance with wage and hour and health and safety law. And finally, I want to say labor must prioritize organizing and apportion our scarce resources to organizing all essential service sector industries during this crisis. And we've all been watching, maybe some of you have participated in numerous job actions and strikes by non-union transit, warehouse, grocery, on-demand delivery workers. And this may well be a 1930s moment. But what has to be first and foremost with labor is that organizing doesn't happen incrementally. It happens in spurts and in upsurges. And if we look just at the period of 1934 to 1939, union membership increased. It more than doubled from 11 to 27%. So labor now, in terms of building community labor coalitions to support organizing, training worker organizing, developing comprehensive corporate campaigns to find out hooks that you have on an employer. My union spends a lot of money looking at employers who get public money or use public property, because we can get so-called labor peace agreements when land use law is approved for new developments. But ultimately, labor, coming back to the Economic Bill of Rights, must champion, when we look at the healthcare issue, that healthcare is a right. It includes comprehensive paid sick, safe and healthy workplace, and single payer healthcare. So let me stop there.
All right. So the next thing that will happen, 1 second, is that we'd like to get some discussion going. So hang on really tight and everybody will be sectioned off into rooms for discussion.